Hi everyone, my name is Jordan. Here presenting with me today is Molly, Aeris, and Cameron. Our case study for you is on Craig, who sustained a complete C5 spinal cord injury. We'll start with his occupational profile before moving on to occupations, performance patterns, and performance skills. To start off, Craig is a 36-year-old Korean male, and he sustained a complete spinal fracture at C5 while he was stacking shelves in the store which he owns. He has no past medical history and does not have any comorbidities or other illnesses that we need to know. His current housing situation, both Craig and his wife live downtown in a one bath apartment on the 5th floor. There is an elevator in their facility. Both him and his wife, Elaine, live alone, but their families, who are both of Korean background, live very, very close to them within the community. Both him and his wife are of Korean heritage, and Craig's family still holds fast to their beliefs on health and family. We did a lot of background research on this topic to make sure that we addressed this before deciding any interventions, plan, treatment, or even addressing Craig's goals. And I believe we'll talk about that later in the presentation. But for now, it's very important, especially as occupational therapists, to address that Craig and his family hold fast to their Korean beliefs on health and family. Craig also has the belief that hard work and persistence lead to success, and he is typically quite an optimistic person. Although after his injury, Craig has become quite bitter, angry, and frustrated. Two of Craig's roles: he is a husband and an entrepreneur. He sustained the injury while he was working and stacking shelves. And although it's not recorded under roles, Craig and his wife both hope to be parents one day. Before his injury, Craig was very avid in outdoor activities. He's an avid hiker, biker, and was very on his feet all the time. Because him and his wife wanted to start a family, and it was her aspiration to become a stay-at-home wife and mom, Craig has been spending a lot more time at his store, and before he sustained the injury, he was working approximately 70 hours a week. Possible interventions the occupational therapist would work on would be educating Craig and his caregiver, whether it be his wife or his father, on the prognosis. It would be hygiene, dressing, feeding, or even social participation. It is important to note that in the initial evaluation, the occupational therapist did test vision, sensation, motor, and a few different other areas. We put that feeding would be the primary area of self-care the OT would focus on within the acute care setting. And the reason for this is feeding is a very basic ADL that would allow the patient some kind of level of independence. With a C5 injury, Craig would be almost completely flaccid below the neck, but have some minimal activation of his biceps, possibly even his deltoids, which would potentially allow for a tenodesis grasp and use of some adaptive equipment. For social participation, we suggested this as a possibility due to his emotional state. Craig is despondent and upset and grieving over his current state and injury. We would recommend some kind of support group, whether it be in the hospital or community, in order to promote hope for both Craig and his wife and give them the opportunity to learn from others' experience. Moving on to performance patterns, we wanted to address one particular question, which is how have Craig's roles been affected and what can be addressed in acute care? As I mentioned early, Craig is a store owner, and although he might be able to return to work, um, he would probably need transportation and he would possibly need to hire additional help, especially when lifting objects or moving items, shifting items throughout the store. Craig would not be able to do that alone, and it would probably be important that he hire someone else. As a future father, because of his injury, they would probably need to seek alternative means of having children. But as occupational therapists, it's quite important that we educate Craig and his wife on typical erectile and ejaculation dysfunction that comes with a complete C5 injury. I know in Dr. Hayes' class a few semesters ago, she provided incredibly helpful pamphlets and information on how to recover or adapt sexual function even after a spinal cord injury. So there is evidence to support a healthy sexual lifestyle even after paralyzation. Also, it's important to educate Craig on the importance of hygiene and early intervention. Finally, as a husband, Craig wanted to support his wife by allowing her to stay home when they had children. Due to this injury and the time it will take and the support Craig will need, his wife will most likely not be able to quit her job and stay home as she originally intended. We identified 8 key performance skills. This would be coordinates, positions, manipulates, energy, endurance, sequence, adaptation, and knowledge. Craig will need to coordinate his body during different tasks, such as dressing or doffing a universal cuff. He will also need to position his arms, head in preparation for transfers. He will need to manipulate, and this might be possible through the tenodesis grasp, and also learning how to release the bicep since he will no longer have his tricep activation. Energy in the OTPF is classified as sustained effort, which Craig will need during activities, tasks, and occupations. For endurance, it's important as occupational therapists that we minimize the energy output and that we work with Craig on energy conservation techniques. When focusing on sequencing, although Craig used to be proficient in eating, dressing, transfers, and other occupations, he will now need to relearn how to sequence these basic tasks. For adaptation, not only will the environment need to be modified and adapted, but Craig will also need to use adaptive equipment such as a universal cuff. And then finally, knowledge. As we mentioned before, there's going to be many different areas in which the occupational therapist, the nurse, and the doctor educate Craig. And even after leaving acute care or even possibly rehabilitation later on, There will be many years of learning and acquiring new knowledge as to how he will interact with his environment and new occupations. And then finally, moving on to motor skills. As I talked about a little bit earlier, with a typical complete C5 injury, a patient would typically be flaccid below the neck, minus some bicep and deltoid activation. This bicep and deltoid activation would allow for weak elbow flexion and possibly tenodesis grasp. We saw this a few semesters ago when we were learning about different neurological impairments. We watched videos on how patients can use tenodesis grasp both to self-feed as well as move to edge of bed, toilet, and even dress. This injury will affect all areas of occupation that Craig participates in. Even though he will be able to return to some of these occupations, such as dressing and feeding, through adaptation and modification, there are many occupations Craig will not be able to return to, potentially such as driving. Because of this, it's very important that occupational therapists focus on strengths and we focus on the client in order to make his life as meaningful as possible.
Hey guys, so this is Molly, and I'll be going over the client factors for Craig, our spinal cord patient. So, as you guys know, client factors are going to involve his values, belief, and spirituality, his body structures, and then his body functions. So, let's start with his values, beliefs, and spirituality. So, some values that we deduced from just reading his information and his occupational profile are that he values family, hard work, which we see a lot through him running his business, working so hard, and also wanting to just work hard enough to where his wife is able to stay home with children in the future. And then we know that he values his education. And some beliefs that we've seen are traditional Korean beliefs. So we were directly told that in our case study. And so things that affects for his care is just that his family is very involved and they really want to be part of his recovery. Um, and that also goes into some things about just like health and wellness and yeah, the way that he carries out his care and stuff like that. And then as far as spirituality, just from information that we saw about having traditional Korean beliefs, and then some information from one of the situational questions that Cameron will talk about later. There was a religious tradition that they showed, and so I felt like that pointed to Buddhism. So that's that, and now we'll go on to his body structures. So I want to start with his nervous system structures. So just some innervations that will be present after his C5 injury. So muscles that would be fully innervated still would be his head and neck muscles, the coracobrachialis, pectoralis muscles, and the trapezius. And then things that would be partially innervated would be the serratus anterior and the biceps. And then de-innervated would be the triceps, his wrist muscles, hand muscles, and then trunk and leg muscles. So moving on, body structures to skin. So the biggest thing that I want to talk about with skin is that he's at a high risk for pressure sores. So we just want to point that out, knowing that he doesn't have trunk or leg control and he doesn't have sensation below C5. He will need to be really careful about pressure sores. And we as the OTs need to make sure that we educate him on pressure relief and that he's on a pressure relief regimen and a schedule so that he's regularly moving his body and figuring out how to relieve pressure. And so for a while, he will definitely need nursing staff and family and other practitioners to help him with pressure relief because he doesn't have very much control or strength really right now to be able to move himself. But eventually we have ordered a power chair for him as far as our case study is. So we definitely need that power chair to have the capabilities to completely tilt and recline to completely relieve pressure from his lower extremities. So we learned a lot about that in our wheelchair lecture last semester, and just about how much he can really do that on his own once he has the proper chair. So I think that's really cool. And then I just want to talk about splinting. So some splinting that we would do would be for contractures and to facilitate the tenodesis grasp. And something that we want to be aware of with splinting is that he could experience skin breakdown. So we want to watch for that and make sure that he's on a good schedule for his splinting. So now I'll move on to body functions. So the first part of that is going to be his mental functions. So as far as cognitive functions, we saw no deficits as far as the case study told us. And then going on to his emotional functions. So one of our questions was about stages of psychological adjustment and just kind of where he's at in that process thus far, like as we're seeing him, quote unquote, in our case study. So the stages that we read into were shock, denial, anger, and acceptance. And we believe that he's in the denial stage just based on some of the questions he's asking, and he just is still having a lack of understanding of what his life is really going to look like. So we feel like he's in denial a little bit with that, just thinking, or he has mentioned wanting to walk again, and I'm looking forward to the day when I can walk again, but we know based on his level of injury that he's not going to be able to do that. And so definitely having to be sensitive and discussing that with him in a way that is gentle, but also straightforward. And so again, Cameron will talk a little bit about that later, just in the situational questions. And then another question we had about emotional functions is coping mechanisms. So some that we thought could be helpful and appropriate for him would be family support, music, meditation and relaxation, and then health and wellness. And some psychosocial supports that are available to him would be his family. And we think that a psychologist, either in the facility or outside of the facility, would be appropriate, just coping with all that he's coping with now. And then perhaps even a chaplain at the hospital. And then we, as the OT, also have to be a psychosocial support to him to some extent. So now moving on to sensory function. So we know based on his level of injury that, and based on his ASIA scale testing, that his sensation is absent distal to C5, so distal to his injury. So now we'll go into muscle function. So one of our questions was about assessing Craig's upper extremity status. And some assessments that I chose for that would be manual muscle testing, the capabilities of the upper extremity instrument, and the spinal cord injury independence measure. And I just got to read into some of those. This was actually interesting for me because I know a lot of like strength assessments and range of motion assessments, things like that, but not as many for spinal cord. And so I felt like I should find some that are more appropriate to his specific injury, because you don't just want to do something generalized, because he will obviously have very different function. So now going on with more muscle function. So we know that he's experiencing flaccid paralysis, and this is just due to the denervation of his muscles. And so some interventions that we could do to address that would be passive range of motion, mirror therapy, electrical stimulation or E-stim, mental practice. And so just having him go through those activities in his head, and that will help his brain retrain his muscles, and then some active exercises. So next we'll go on to movement functions. So I wanted to talk a little bit about movements that will be lost based on his injury and movements that he will retain. So he will have lost most or all shoulder extension, elbow extension, and then all wrist and hand functions, as well as trunk and leg function. And then movements that are retained would be head and neck control, some shoulder flexion. So we saw that some of that will be possible for him, probably in the long run, because right now he's experiencing flaccid paralysis all throughout his upper extremity. And then elbow flexion, he should have some capabilities there, and forearm supination. So now moving on, more movement functions. One of our questions was about what interventions we could do to train him in sitting tolerance. And so I thought an appropriate one would just be tabletop activities where he's having to reach and move his body a little bit, and he would need to be in supported sitting. So obviously this one is sort of complicated because he doesn't have trunk control, and he doesn't have a lot of upper extremity control as far as reaching and elbow extension, like I just talked about. So definitely would have to look at all the details of what that intervention would entail. And another question we had was about an appropriate way to transfer this patient. And so, because he has very little capability of helping in the transfer, we thought that a mechanical lift would be most appropriate, and that may require help from a PT or other practitioners. And next, we'll move on to his cardiovascular and hematological body functions. So, just a couple things here. Um, we had a few questions about autonomic dysreflexia. And so, as we all know, autonomic dysreflexia is something that's really common with spinal cord patients. And this is when they experience these symptoms when there's a noxious stimulus affecting the parts of their bodies that they can't feel, so where they've lost sensation. And so, like we said, for Craig, that would be pretty much all of his trunk and lower extremities. And so he is very predisposed to experiencing this because there's so much of his body that could be either that could be hurt in some way, and he doesn't know. And so essentially what happens with this is that the body is trying to send a signal up the spinal cord to his brain to tell him, hey, there's something poking your leg, or hey, your clothes are too tight in that area. But the signal is stopped at the level of the injury. And so the body has to find a way to get that message to the brain. And so it sort of, the way that I read about it was that it kind of loses control and kind of like falls into this weird cycle of trying to send the signal, but then the signal isn't able to get there, but the body's still sort of in like a fight or flight mode. And so some symptoms that he may experience would be headache, sweating, high blood pressure, flushing above the injury, so his skin would be red and hot, and then just a slowed pulse. And so if we notice these things during our care, what we need to do would be get him sitting upright and lower his legs, and that would just kind of start to regulate things. But then we need to remove the noxious stimulus. And so this could be a lot of different things, as small as an ingrown toenail, maybe tight or restrictive clothing. Something that's pretty common would be a full catheter bag or a bent line. So with that, we know that when you're working with patients, there are so many lines and just things coming out everywhere. And you have to be really careful with that, but especially with a spinal cord patient who doesn't have feeling. If you're pulling on that catheter bag or the line, or you've left it hanging on the bed, I've seen that done before, and you start to go away with the wheelchair, he's not going to know that something's happening, but you need to be aware of all of those lines at all times. Another thing that could cause autonomic dysreflexia would be a pressure sore, and then just a few other injuries, so things like a bruise or a scrape or even a fracture. I read that that's possible. So yeah, there are a lot of things that could be caused. And so essentially, you just want to be really careful when you're treating spinal cord patients, knowing that they don't have sensation. You're not going to get those signs as easily as you do with a patient who can feel. And so you have to be aware of those things and definitely check for that if you see these symptoms. And the next one to be aware of is orthostatic hypotension. And so, as we know, this is a sudden drop in blood pressure when the head is raised. And so, a lot of times, what you see, or when you see this with a patient who is walking and things, would be they've just been laying in their hospital bed all day, and then they stand up to do do treatment with you, and they're suddenly lightheaded and dizzy. And but obviously with Craig, that would look a little different. And so it's probably in a situation where he has been lying supine in his bed a lot of the day, or maybe it's first thing in the morning and you're coming in to treat him and you sit him up or get him to the edge of bed, you're doing bed mobility, or you're moving him to the wheelchair. And so this is just caused by being lying flat for a long time, and his blood pressure and pulse and everything has gotten used to that position, but then he changes position and then it's harder for his blood to get up to his head. So some symptoms that you would see with this would be chest pain and heart palpitations, dizziness or loss of consciousness, shortness of breath, and then nausea, sweating, or fatigue. And so what we should do if this happens during our treatment session with Craig would be to recline his head and elevate his legs. And so just kind of regulating that blood pressure and his pulse and getting him calmed down a little bit. And as we said, he is predisposed to this because of his injury and just spending a lot of time lying down or sitting. So we need to be careful of this. And some precautions that we can take would be having him wear compression socks. So as we know, with his injury, since he doesn't have sensation or innervation to his leg muscles, his muscles are not able to contract and send that blood back up his body. So compression socks may be helpful in just regulating his circulation. And if possible, we want to keep his head elevated when he's in supine. And so um, if he's comfortable with this, he could sleep with his head a little bit elevated, especially in the hospital when he's going to be lying down a lot of the time. But if not, just having him do that maybe throughout the day, like if he's just lying in bed watching TV or spending time with his family, we want his head to be elevated because that'll kind of keep his body used to regulating his blood pressure in that position. And then also just making sure he's getting plenty of fluids to keep his circulation and everything working well. So that's all I have for his client factors. And now I'll hand it off to my teammates. Thanks, guys.
Okay, so now we're going to discuss the context and environment, also the adaptive equipment, and the theory and evidence that we use for this case. So first, let's look at the cultural aspect. So Craig and his family believes in the Korean health beliefs, so which they tend to use herbs, acupuncture, and also cupping. As you can see above is a picture of cupping and also acupuncture, so you can get a visual representation. Next, their medicine is based off the yin and yang, which involves the balance of fire, earth, water, wood, and metal. So they do not they do not take or believe in taking any medicine from doctors or any prescribed medicines. They believe in these natural remedies. Also, they do not believe in taking any painkillers. They control their impulses, especially men. They will control their emotions. They will not allow you to see them in pain. Also, Koreans avoid eye contact with strangers and they prefer to do day to day tasks in silence for extended periods of time. So, as an OT, when we are working with a patient who believes in the Korean health beliefs, you should definitely include them on the interventions and make sure that it is aligned with their culture. Next, we want to look at Craig personally. So he is considered middle class. Also, he is a business owner. He's a college graduate and he's 36 and have a strong marriage. Next, the temporal, the stage of life. This is very important when we're thinking, this is very important to think about when we're coming up with interventions and also things that Craig will probably would like to focus on more. So Craig just recently started his own business and also him and his wife were preparing to have their first child. Craig's business is not financially stable because it's new. And so this is something that he will probably really want to get back to. He was working 70 hours a week, and he do have two part-time employees. Next, some of the physical barriers that Craig will probably encounter is the available assistance. He would definitely need more assistance throughout his life. His spouse do have a job. Hopefully his parents can chip in or his sisters. Accessibility to toilet facilities. So he would definitely need to make sure that he has room when he goes into different facilities to access the restroom because he will have a power wheelchair. Also, when it comes to transportation, they would definitely need a car or any a bus or different types of transportation that they could get within their area for transporting a wheelchair, especially his power wheelchair. Some modifications that Craig and his spouse will probably make in their house. Um, let's start with the bathroom. So in the bathroom, they would definitely probably need a rolling shower and also grab bars. In the house, they would probably need to move around their furniture so he can maneuver around in his wheelchair. In the kitchen, all frequent use items are in reach for Craig. And also in the bedroom, they could place bed rails on their bed. This will allow for him to transition from the bed to the wheelchair and also basically bed positioning. This will help make it easier for Craig. So social, some of the relationships I'm talking about is between him and his spouse, him and his parents, and also potential support groups. So we definitely want to educate the family on general information about the statistics of the spinal cord injury, and also make sure that they know what is a complete C5 spinal cord injury. Also, we definitely want to make sure that they know the complications after a spinal cord injury as far as the bladder, pressure wounds, spasticity, pain, and autonomic dysreflexia. We definitely want to make sure that we educate the spouse on pressure wounds and how to prevent them, as far as making sure that they do regular pressure relief and when they make sure they rotate him in bed and also reposition him, making sure that they complete their skin inspection, also keeping the skin dry and clean, and maintaining uh, hydration and also eating well. So some organizations that the OT could possibly hand out to the clients or give them general information about is the Christopher Reeves Foundation, also the American Spinal Injury Association, and the United Spinal Injury. These organizations provide great information about spinal with patients with spinal cord injuries and just different information that they will probably need throughout their life. Also, the OT will probably would like to provide support groups for Craig, and some support groups that they probably will give him for resources is the Lone Star Paralysis Foundation and also the Tear Foundation. It's very important for Craig to build those relationships with those support groups because it could allow help him maneuver through life differently. Because these are people that's going through the same thing that he's going through. Also, it can help with his mental health, so he would not get depressed, and it will kind of help keep cheering him on in this new life that he has to adjust to. So next, we're going to talk about the adaptive equipment that is commonly used in the acute care and also his wheelchair. So some adaptive equipment that the occupational therapist would start using is the universal cuff. And the reason why they would start using the universal cuff because it helps in ADLs such as self-feeding and hygiene, which is worked on in acute care. Also, the universal cuff helps restore and preserve function and mobility of upper extremity. And doing self-care activities early in recovery, it can restore a sense of self-efficiency and also self-esteem. So the universal cuff can be used for feeding. Also, you can attach the toothbrush to the cuff, to help him brush his teeth. Also, you can attach a comb to help him comb his hair and different things like that. So this will be a great adaptive equipment to use for Craig. Also, some additional adaptive equipment that the therapist probably uses a scoop dish, a long straw, a swivel spoon, wrist support, mobile arm supports, also a wrist and hand split, day or night wear. And I put a picture of the wrist and hand split because we just made this split in Dr. Lohman splint class, which I thought was very cool. And in this case, to try to transfer the knowledge in this case is very important for Craig to have a wrist and hand splint so he won't get contractions in his wrist or his hand because they're not mobile due to his condition. Next, we're going to discuss his power wheelchair. The I got the power wheelchair from the PowerPoint that in Dr. Loman class, the lady came and spoke about the different types of wheelchairs. So it gives you a better understanding why the name of this wheelchair is Group 3 KO848. And the reason why I chose this wheelchair is because it helps with day-to-day energy conservation. Also, it is covered if the patient suffered a spinal cord injury when we're dealing with the insurance companies. Also, it is used for a patient who has high risk skin breakdown and cannot perform functional weight shift, which in this case is very important for Craig catheterization, and also someone that has increased tone and spasticity, which Craig does. We definitely want to make sure that he gets a pressure relief cushion so he would not get any pressure wounds. Remember, if a client gets pressure wounds, they will not be able to get any rehabilitative service such as OT or PT. And two of those wounds are healed. Also, this is the joystick. So this joystick is commonly used for patients with C5 and C6 injuries, and we thought this would be pretty good for Craig's condition. It's easy, it's small, but however, there are different types of joysticks, and we probably want to get the client's input on what type of joystick that he would like or he can adjust to. So some other things that we want to look at as far as his wheelchair, we definitely want to make sure that he has alternative drive controls. So as far as the different joysticks I was talking about earlier, they also have like different buttons and so forth. You can use, you know, his head to control the wheelchair. And so it's just different drive controls that you can use within the wheelchair. So we just have to consult with the client to see which one they would like. Also, the power positioning system. So this wheelchair can definitely tilt and it could definitely recline, which is good to help with those relief from those pressure spots on his bottom. Also, a solid backrest support and trunk support is very important in this case because his trunk support is not stable. So lastly, I want to discuss the theory and evidence that we based off as far as choosing the adaptive equipment and also focusing on the certain type of short and long-term goals and interventions that we provided for Craig, which you're going to learn about later on in this video. So the first thing I want to discuss is we chose the rehabilitative frame of reference. And the reason why we chose this is because it's used for adaptive equipment and compensatory strategies to the environment or the occupation. Um, this is very important in Craig's condition because he will be adapting to his environments. He will need to use adaptive techniques in order to accomplish some of his ADLs or IADLs. Also, this frame of reference is designed for spinal cord injury patients in our clients whose injuries are permanent. So in this case, Craig's injury is permanent. He will remain in this state. We got our evidence from the Roman textbook, which we are familiar with, and also evidence from Pedretti. They had good resources on why we should use the universal cuff and also the power wheelchair and other things that you will see later on in this video. We decided to use the PEO model because it is very common in acute care. A lot of OTs use this PEO model because they focus on evaluating the patient and also placing the patient in different areas after discharge. So that's their main focus. And so in order to do this, the OT must first evaluate the person. What is wrong with the person? In this case, Craig's condition, he is a spinal cord C5 complete patient. So he has different comorbidities and different things that he cannot do and different things that he can do. So the therapist is looking at all of these things. Also, the therapist will look at the environment. So what type of environment that Craig will be living in. Also, does his future look like? Do he need inpatient or outpatient or so forth? Nextly, the occupational therapist will look at the occupation. So what are some occupations that Craig needs to focus on? In this case, he needs to focus on all the occupations because he needs to adapt to his disability now. So this is why we use the PEO model because it kind of ties in everything together in acute care. Remember, acute care is fast paced. The patient probably stay in acute care for 3 weeks at most. So this is a fast paced setting, and the therapists have to make sure that they intertwine all these, the person, the environment, and the occupation.
So now let's move along into intervention plan and goals. So here's some key OT assessments for spinal cord injury. We should definitely create an occupational profile. We should definitely address supports and barriers to occupational engagement, occupational history, and values and interests of our client. The age impairment scale, it can be very helpful with kind of mapping out the body for like motor and sensation with determining like the myotomes and dermatomes. And additionally, we should just sensation um, for pressure ulcers. That skin integrity is very important. Pain, we should definitely address that every time we see our patient. It's very determinant of our outcomes. Range of motion, manual muscle testing, and grip and pinch strength is very important for us to assess, especially with Craig since he's a C5 injury. We should definitely see and get a complete picture of his upper extremities. Um, Very limited because of paralysis in his fingers and wrists, but we still have the biceps and those deltoids, which can help with uh, our functional level. Now, spasticity is very common with spinal cord injuries, so we can definitely use the modified Ashworth scale to kind of track this progress. Um, Coming up with like functional levels and self-care. And then vision and cognition should also just be checked out just to see what's really going on to see if there's any additional problems. So after we do our evaluation and assessments, we should create a problem list. And with our problem list, we should definitely prioritize. In an acute setting, we definitely cannot address all the problems, so we definitely need to pick out the most important ones. So our top two, dependent in self-feeding and dependent in self-care, like in hygiene, is very important for us to address in this acute stage. Um, Addressing these two is very important for preserving joint integrity and mobility, and also just restoring function in an early stage can be very beneficial. Since Craig is a C5 complete injury, he's definitely experiencing that neurogenic bladder. So our bowel and bladder management should definitely be addressed to prevent future complications. That loss of sensation is very important. Um, like I mentioned earlier, for skin integrity and preventing those pressure ulcers. Paralysis, spasticity, autonomic dysreflexia, and these last two I feel are the most meaningful for Craig, but maybe not appropriate for us to address completely in acute care. Now, his sexual functions should definitely be addressed because him and his wife have definitely expressed of wanting to start a family in the future. They mentioned that, they're putting it on hold because they wanted Craig's business to jump off. Now, talking about Craig's business, we should definitely address his job performance. We would love for Craig to go back to work and run his business as independently as possible and make modifications. But like I said earlier, in this acute stage, it's probably not appropriate for us to address, but definitely should be addressed down along the line. So we prioritize our problem list, and now we have to create some long-term goals. And those long-term goals should definitely align with our top three problems. So our first long-term goal is the patient will complete the task of self-feeding with mod assist and adaptive equipment as needed. As we mentioned earlier, that adaptive equipment can be a splint, the universal cuff, or like a mobility arm support. Our second long-term goal is the patient would demonstrate proper hygiene with moderate assist using adaptive equipment. And the adaptive equipment is similar to what we would use for self-feeding. And our third long-term goal is by the end of 2 weeks, the patient will recall proper bowel and bladder management. As I mentioned earlier, it's very important for us to address this to reduce complications of urinary tract infections or constipation and rehospitalization. Now we're going to create some short-term goals, and our short-term goals are going to be aligned with our long-term goals that we created. Um, so by the end of 1 week, the patient will complete the task of self-feeding with max assist and adaptive equipment as needed. Short-term goal number 2 is by the end of 1 week, the patient will recall 3 risk factors of poor bladder and bowel management. Number 3 is by the end of 1 week, the patient will be able to brush his teeth with moderate assist and adaptive equipment as needed. This is addressing that personal hygiene and self-care. And by the end of 1 week, the patient will be max assist in mobility. We added this max assist in mobility because I think this is important for with self hygiene, like it's taking like a bath in the bed or helping with transfers. He still has the ability to do the elbow flexion and some actions with his shoulders. He can definitely assist a little bit. Now let's talk about some situations that may happen with Craig and how we can respond to those. So our first situation is you're working with Craig and he starts to perspire and complaining of a pounding headache and chills. What does this indicate and what is your response? This indicates the autonomic dysreflexia. If you are in a situation, you should definitely place your client in an upright position, remove anything restrictive, check the bladder and see what's going on there. Drain the bladder, check the catheter tube and see if there's any nicks or knocks in there. And then also monitor that blood pressure. Okay, situation number 2. During treatment session, Craig talks constantly about the day that he will walk and motivates him to participate in his OT sessions and gives him hope. How might you handle this? I would definitely acknowledge and validate Craig's feelings and wants of thinking of the most highly positive outcome of this situation. But we don't want to give like false hope. And to be honest, based on evidence and prognosis and outcomes, for his injury of being a C5 complete, walking is just likely not a feasible goal. So as a therapist, I should instill hope in him that he can still live an independent, fulfilling, meaningful life with this occurred injury. So our third situation. Craig has developed moderate spasticity in his lower extremities and mild spasticity in his upper extremities. He is anxious about this change and he thinks this means he is getting worse. How might you explain the presence of spasticity to him, and how can spasticity be useful in your treatment program? So spasticity is a result of disruption in signals from your spinal cord to your brain. And these disruptions cause your body to be sensitive to stimuli, and your body reacts by increasing tone, just tensing up your muscles. Now, severity spasticity can cause some problems down the road, like contractures and limiting range of motion, and just limiting like participation in occupations, decreasing like function. So, but moderate spasticity can be beneficial. It helps maintain muscle mass. It assists in preventions of pressure ulcers by facilitating some blood circulation. It helps with range of motion and like bed mobility. So actually what he's experiencing now can help me out as an OT and his participation in occupations. So it's not necessarily a bad thing, and he really shouldn't be too worried about it. So our last situation. One afternoon, you enter Craig's room to find it filled with family members from both sides. They have set up a small shrine and seem to be involved in some sort of religious practice. Your schedule is tight, and this is the only time you have to see Craig in the afternoon. What do you do? I'll be conscious and respectful of Craig's culture and religious background and possible implications for his emotional expressions that you've been getting lately. Um, he's been kind of angry, a little depressed, and kind of confused about his situation. Um, that's what's going on right now. So I will write a missed visit note and coordinate with nursing staff and also with his family to schedule a time that would be beneficial and doesn't really cut into his religious practice, and try to modify my around that. So allowing Craig to participate in his religious rituals is important. It may help improve my participation in therapy, which can lead to better outcomes. Craig's religion can be a source of efficiency, self efficacy, self motivation, and resilience, which can be very beneficial to my intervention plan and lead to better outcomes in his rehab. So let's go along to our discharge. So Craig is in acute care. The goal for an acute care is to be seen 3 to 5 days per week. His initial performance was being dependent in all the ADLs, including bowel bladder management, feeding, and hygiene tasks. Craig's ending performance is using adaptive equipment to assist with feeding and self-care with moderate assist. He's able to recall proper and bowel bladder management. He demonstrates proper hygiene with moderate assist and using adaptive equipment. And right now, he's been using a power chair for 2 hours per day, and we went ahead and ordered a power chair for future use. Now, for our discharge recommendation, Craig is still experiencing some spasticity, the autonomic dysreflexia, orthostatic hypotension. So he may need some more medical care. But then also, Craig is young and he's motivated, and we think he can probably tolerate longer treatment and a higher intensity. So we definitely going to recommend him to be discharged to inpatient rehab. Now, in conclusion, we navigated through this complex case study of Craig, who suffered from a C5 complete spinal cord injury by using the OTPF and the OT process.